Thank you for the kind introduction. That was very nice. Thank you. I decided not to have any formal slides today. I knew it was going to be a small group, and I thought it was best if maybe I got up here and talked about what goes through my mind or oncologists' minds when we make decisions. And that may be more helpful. And this is all about what one does with liver disease or cancer in the liver, or cancer maybe anywhere else in the body, and what kind of options do we have, and how does one make decisions about using different types of treatments. And so let's just take the idea of cancer that's in the liver and what one looks at when one makes a decision. One wants to know if the cancer started in the liver or has it metastasized to the liver. I think that's one distinguishing thing one needs to know. And if it has metastasized to the liver, where did it originate from? Did it originate from breast? Did it originate from colon? Did it originate from lung? Did it originate from what we call the bile ducts? And so that comes into play as well, because different types of cancers have different biology. And our treatment today and in the future is all going to be about treating biology of cancer. And I think that is what I'm going to leave you with, because biology is everything. Is the cancer very aggressive? Is the cancer slow growing? Do these cancers have likelihood to go to certain parts of the body? When do they go to these bodies? Can it be contained? A pancreatic cancer that goes to the liver is totally different than a colon cancer that goes to the liver, and how one would potentially treat it. So it's important to know where the cancer started and when it goes to the liver. The other important things to know is, if it's in the liver or the lung, is how much of it is in the liver. Does it take up 70% of the liver? Does it take up 20% of the liver? Or does it take up 90% of the liver? Those are important questions when one has to make a decision about treatments. Certainly, you can remove about 70% of the liver and still have a functioning liver as long as you have a blood supply. But you can't take 90%. So it's important to know how much of the liver is involved and where in the liver is it involved. Does it leave a certain amount of normal blood vessels? Does it entail what we call the portal vein? And Dr. Acquisto will probably go over a lot of this when we talk about it. The other thing that one talks about is the size of the tumor in the liver. And then how much disease is outside the liver. So let's take some of these separately. Certainly, if a cancer starts in the liver, what we call hepatocellular carcinoma, and it's only in the liver, liver-directed therapy is the primary treatment. If it's very, very early, surgery is the treatment of choice. If it's in multiple areas in the liver or very large lesions, then certainly doing something like what's called giving chemotherapy right to the liver, or doing Y90 or spheres, make a lot of, can contain and actually treat those tumors. If it's a very small lesion and it's liver cancer and a person's not a candidate for surgery, then doing something called RFA, which is radio frequency ablation, is something that can be done. So size, location are very important, and biology. If this cancer has gone from the colon to the liver, that's a very common area, and sometimes it can be the only area that the cancer goes to, and doing liver-directed therapy is very good to do. We know that liver-directed therapy for certain types of cancer makes more sense than others. Colon cancer can make a lot of sense for. What's called a neuroendocrine tumor can make a lot of sense for. Bile duct tumors it can make sense for. It doesn't make as much sense for something like lung cancer or breast cancer. In those situations, the biology is such that the disease is more than likely going to pop up something. If you just treat one spot, it's not going to be that helpful because you're going to have other areas popping up very soon. So where the cancer starts from is very important. And when we think about liver-directed therapy, we also think about how much disease is outside the liver. If you have none, it can make a lot of sense to do because you want to control the disease in the liver. If you have a lot of disease outside the liver, lung, bone, and to just think about treating the liver may not make any sense because while you're treating that liver, those other areas then can get worse. So I'm spilling out a lot of things here, but what one wants to do in the long run is to take all of this information, put it together to make appropriate decisions. I hope this is making sense. The other thing I think can make sense is that treating liver lesions, two situations I can think of that three situations. One is if it's only in the liver, and there's a potential one can resect it and go after potential cure. The other thing is that you have symptomatic disease. It's causing pain, causing symptoms. If you treat it with local treatments, you can cut down those symptoms. So it makes sense to do something to help symptoms. And let's say you have liver mainly disease and very little outside the liver, treating the liver primarily can potentially control that disease in the liver, and you don't have to worry if you only have one or two lesions in the lung or elsewhere. Now, what kind of treatments do we have for cancer that's in the liver or elsewhere? There's chemotherapy, and certainly chemotherapy can be very effective for most of the cancers we see, but not every cancer. Certainly it's effective for colon cancer. It's not very systemic chemo is not very effective for like something primary liver cancer. In that situation, local treatments to the liver makes more sense. We also have liver-directed therapy. You're going to hear more about that from Dr. Acquisto. And we also have, nowadays, all kinds of new treatments are coming into being, what we call targeted treatments. And in our research program at the present time, we now have immune therapy that we're giving. We have a drug for certain cancers that turns off the brakes of the immune system and allows your immune system to rev up and go after the cancer cells. And we have that for many types of cancers at the present time, melanomas, lung cancer, and it looks very promising. We also have treatments that go after, when you think about chemotherapy, you think about rapidly dividing cells. And traditionally, you think about giving these drugs to stop rapidly dividing cells. But nowadays, we know that cancer is more than just rapidly dividing cells. You need a blood supply for cells to get bigger. You need to have cells, there's something called apoptosis. Every cell in your body is aimed to die at some point in time. And cancers, some cancers, basically lose their ability to die normally. And one of the ways we can treat cancers many times is to turn on their ability to die more normally. And there's research is going on about that. We have a new drug for leukemia that's not on the market yet, but it's not chemotherapy. It doesn't go after proliferation. All it does is turn on the cancer's ability to die. And we've given this to 5 patients or 4 patients. Every patient we've given it to, except for one, is doing great. And the biggest problem we have with this drug is that it can be too effective. The cancer could be there one day and not there the next day. And what happens is that we have to worry about the breakdown products of the cancer. So targeting certain aspects of the cancer, what's different between the normal cell and the cancer cell to develop certain drugs that can go after that is a way of treating cancer too. So here I am sitting up here and I've told you 1,000 different things, and you're going to say, how does one proceed and put all this together? And I think in oncology today, the best thing you can have is teams of doctors working together, what's called a multidisciplinary team. We have the cancer surgeon, you have the pathologist, you have the radiologist, you have the interventional radiologist, you have the medical oncologist, you have the radiation therapist. We all sit down together and we take out the slides, we take out the pathology, we look at the patient in total, what kind of, how old they are, where the cancer started, where it's at, how much cancer is present, how much cancer is not present. We put all of that together, and then we look at options for that patient, and we look at the potential best way to treat that patient to maximize the benefits and minimize side effects and discomforts. I think doing that, we can maximize how patients can do. We can decide, we have a meeting every month where we meet with the IR people. We talk about, is this patient a good candidate for Y90? Is the patient good? Should that patient continue on chemotherapy? Research nurses are there. We look at, is standard treatment best? Is something investigational best? And how one should put all of this together. And we also have the patients don't come to these meetings, but they're part of the decision as well. We will then present the information to the patient and say, this is what we think would be best. These are your different options, and we get their input as well. And with that, we feel that patients can do the best, keep their cancer controlled, or get rid of their cancer, and maximize the chances of how they're going to do. But the information, and I'll go through it one more time, you need to know the biology of the cancer. You need to know where the cancer started. You need to know the extent of the cancer, localized or diffusely throughout. You need to know if it's just how quickly it's growing or not growing. And by doing, and then you look at all the different options of systemic chemo, localized treatments, and you make decisions with the patient, with the whole team seeing the patients, on how best to go after that cancer. And I think that's how we need to deal with it. Again, it's looking at biology, looking at patients, their characteristics, putting it all together, and looking at options. So what may work for one person may not work for the other. And it's really important to treat that person's cancer individually, and to look at that biology individually. I'll just say one more thing, is that I think that the way I'm going to be treating cancers in the future is going to be totally different than what I've done today in the past. I'm probably going to take this tumor, I'm going to send it out to a place where they'll tell me about 100 different, I'll check for 100 different genes. I'll see how that patient's cancer differs from normal cells and other patients' cancers, and we'll be able to put together a package. It might be like that old pharmacy guy going up to the shelves, a little bit of this, a little bit of that, and going after the person's cancer that way. But certainly, localized treatments are a key part of what we still need to do. And so I've been in this business 30, I'm not going to say, a long time. And it has changed, and it's changing. I think it used to be irrational how we treated patients. It's much more rational, and I think we're going to do far better. And with that, I thought I would now introduce Dr. Acquisto. Dr. Acquisto is our interventional radiologist. He's my go-to person when I need readings done. And he works within this team to pick out the right treatments for the right patients. We'll send him a patient to have maybe seeds given, and he'll say, I don't think this is the best for the patient. So it's a team that you just don't send someone to, they look at you as a whole and to make decisions. Dr. Acquisto is a major part of this, and I think we're going to learn a lot about how he can treat localized problems. Again, that's not for everyone, but it can be extremely helpful when needed. So with that, I would like to thank you for your attention. And maybe before he gets up here, I can answer a couple of questions.
I was going to ask you if you were going to be able to stay for questions. Okay, good.
I made sure I saw my patients this morning so I could be here for a while. Any questions for me? Yes?
But it's kind of, you've been in this for so many years, 30-some. I'm a cancer survivor. Not the type of cancer we'll talk about here today, but I'm a breast cancer survivor, 12 years. Our daughter has neuroendocrine originated midgut, which is why we're here. But in those years, because I refused chemo, I watched my mother and her 4 sisters die, and my cousin, all of it. I'm just wondering, I kind of like Suzanne said, it's every day she's living with the hope. And that's how I've looked at it from day one of mine. So I'm glad my daughter's on that page. But why did it take so long for them to start looking at the individual? And because that's how I looked at it a long time ago.
Well, this is just not new. This is from years and years and years of research.
Okay.
So what the research that we were doing in the 30s, the 1930s not, the 1970s and the 1980s are now paying off with dividends.
Okay, gotcha.
And so we didn't know what a lot of this wasn't known until Crick developed what we know as what the DNA is. So it was the late 1950s and the 1960s that we finally figured out what DNA is. And then it took years to do more with that DNA. And the real explosion now came with them able to sequence the whole genome. So we know all the genes. Now, and that was in the 1990s and the early 2000s. So we always thought from the 1970s until now that targeted therapies would be the way to go, and to figure out what was different between a cancer cell and normal. But our knowledge went from this to this to this, and I would like to think that in the next 10 years it'll go from this to that. It just gets that much more with with these computers and everything. There's a drug that we're dealing with right now that is it's a designer drug. Some of these researchers are able to add this to the drug, remove this, so this drug turns on the immune system, but they put something in the drug so it wouldn't cause any lung toxicity. So some of these young guys are able to take all this information we got and really start moving it forward. but it took time to get going.
My mom's was late 70s, so yeah, at that time it was radical mastectomies and hardcore chemo. And, yeah, so now it makes more sense to me. It's like,
We've always wanted this.
yeah, wow.
Okay.
Wow. So it
It's-
just took this long.
It took this long, but I think it'll take less long to get more information. With that, Dr. Acquisto.